etcétera, etcétera. Y la verdad que sería perder tiempo en algo que prefiero dedicarlo a escuchar lo que nos tiene que decir el doctor Woodall sobre lo que es el rechazo humoral. So, Steve, thank you very much for coming to Argentina, and again, we will listen your talk. Thank you.
Thank you very much. It's a pleasure to be here, and always a pleasure to follow my good friend David Rush. I think you'll find that our two talks, we didn't prepare them or communicate or anything, but I think you're going to find that they're going to mesh fairly well. We see things very similar to the way things are seen in Winnipeg. And one of the things that I want to do today is talk a little bit, not only about antibody-mediated rejection and how it's treated, but also about cellular rejection. You noticed in David's talk that he had a lot of things about cellular rejection. The two are inextricable. They often coexist. And it is really the exception to see an isolated antibody-mediated rejection. Those are unusual. And one of the things that we have not done in transplantation is come antibody and cell-mediated rejection at the same time. In fact, when we go and see those biopsies, my people ask me, what do we do? And what do you do? And so I usually tell them, there's no guidance in the literature for how to treat a mixed rejection. And it's one of So I've looked at biopsies now for over 30 years. All of our patients' biopsies. And back when the donor-specific antibody assays came out, the assays in which you could assay for 200 different HLA antibodies when we were looking at a biopsy, it looked just like cellular rejection, but there would be antibody present. And so one of the things we did at that time, we went back and had Matt Everly review all of our rejections over a 5-year period that in patients that had at least 5 years of follow-up. And we had him classify. We came up with a number of these rejections that had both cellular and antibody, and nobody had ever described this. He said we were trying to create a new entity, and we were saying, no, we're just describing what exists. And so after a prolonged battle with the editor, we actually got this paper published. Now, there were a number of these that were unclassified, but they were unclassified because they didn't have DSA testing at the time. Remember, this is back in 2009. So a number of these patients actually didn't have DSA testing. We've gone since and updated this with almost 200 patients, and the observations still stand. They've changed a little bit, but they still stand. The other important thing to realize here is, just as David told you, look at our data. If you have a mixed rejection or antibody-mediated rejection, you have approximately 50% or greater graft loss within 2 to 3 years. So you're cooking along with a graft doing just well. You have a bad rejection, and that kidney is going to be gone in 2 to 3 years. That's a real problem. So you know that we've worked for many years to improve immunosuppression. The last drug approved was belatacept over 10 years ago. And before that, it was 30 years ago when tacrolimus was approved. So there have been only incremental advances in baseline immunosuppression. You know how we treat rejection? We use steroids and we use anti-lymphocyte globulin. Does anybody here know how old those treatments are? They're 70 years old. They're empiric, they're not specific targeting, and one of the biggest advances that we're going to make, our belief in our program, is the biggest advances in immunosuppression are not going to be baseline new maintenance immunosuppressive agents, but there are going to be agents that abrogate this graft loss to rejection. Something that can take this curve David has given you some idea about that, and I want to emphasize that, and that's what really we want to talk about today. The other thing I want to emphasize to you is we were wrong about this. Okay, this is cellular rejection, 30 straight cellular rejections with no graft loss. Well, what turns out is these are almost all BAMF1A rejections. Okay, when you get a BAMF2A or 2B rejection, you almost always have antibody with it at the same time. So they're inextricable. Okay, those are the ones that cause the graft loss. So we're going to look a little bit more into that. These are number of patients here. This is in the first 6 months of rejection. First 6 months after transplant, these are the distribution of rejections between cellular rejection, mixed, and antibody, pure antibody. Okay. These are late rejections, and as you can see, the proportion's about the same. Okay. Now, a lot of these here are BAMF1As. Okay. Remember, a lot of the 2As and 2Bs are going to be in here. Okay. So these are the rejections that are connoting the risk. So it's some of these and these that are connoting the risk to graft loss. The other thing that we did in this paper, and this is often missed by a lot of people, is applying BAMF criteria when you're looking at a mixed rejection is not an easy thing to do. And sometimes, so the pathologist has got to grade and tell you whether or not the C4D is real or not. They need to grade the microvascular inflammation. And it's not always an easy call. Sometimes they equivocate. We sit and struggle over some at our place. One of the things I asked Matt to do, I said, Matt, just go back and forget the diagnosis of AMR and just classify these as to whether or not there's a DSA present or if it's absent. So that's really easy because it's either there or it's not, right? Here's your demarcation. If DSA was absent, 90% survival at 6 years. But if you had a DSA present at the time of rejection, you had 40% survival here at 3 years. So just the presence or absence of DSA and not the full BAMF criteria is good enough. So we present or not. I don't sit there and worry about if it fully meets BAMF criteria. Okay. That just tells you DSA is a really good marker. It's a good biomarker. The other thing that we did is we went later and classified these as either an early or a late rejection. We still see a hierarchy here, but it doesn't matter whether it's cellular rejection, mixed, or late. These are worse rejections. Okay. Now, in terms of DSA, these are always de novo. These rejections that are mixed, it's always a de novo DSA when it's late, right? By definition. But look at late pure cellular rejection. Early cellular rejection, these are largely BAMF1As, and they respond very well to steroids. The one rejection treatment that we have that's pretty good is steroids for BAMF1A. Steroids are not good for a BAMF1B or greater. And here's your late cellular rejections. Remember, a lot of these are BAMF2As or greater. When you grade a rejection, again, here's a 1A, no graft losses here in early ACR. You have some graft loss here with a late BAMF1A. So late BAMF1As are different. These are very easy to treat. But look at the 2As and the 2Bs. I mean, here's 0% graft survival with a late 2A rejection. Okay, within 3 years, all the grafts are gone. I submit to you that steroids and thymo, these patients are getting thymo. They are very poor treatments, and we need to get rid of them yesterday. We need to find something better yesterday. Well, how do we know when we treat AMR that we've done a good job? And that's one of the questions that we had, and we spent a lot of time working on this. C4D is tough. The pathologist often equivocates on it. Is it circumferential or is it just like spotty or globular? They like to discount the C4D deposition in the glomerulus, which I think is actually When you've got an antibody and you've got graft dysfunction and you've got deposition in glomerulus, to me, that means as much as if it's in a peritubular glomerulus or peritubular capillary. There's no reason to think they should be different. The reason the pathologists don't like to call it with glomerular is if you're looking at renal diseases, native diseases, glomerular C4D will light up a lot of times. So they consider it non-specific. But to me, knowing what's going on at risk for TG, because damaging the endothelium, that's going to translate across the basement membrane to the podocytes, and then you're going to wind up with podocyte damage. Microvascular inflammation is a little easier. Here you go is a peritubular capillary, a couple of them that are just chock full of cells. You saw this in David's slide. But the big thing is your antibody assay. If you have your HLA lab pay a lot of attention to how the assay is done, it can be a semi-quantitative to quantitative assay. In our program, our coefficient of variation day to day on a DSA sample is less than 5%. We do them robotically. When we go and compare a patient, you say, okay, he was at 8,000 MF5 when we treated him. Now, 14 days later, what's he at? We'll run those two samples together in the same batch, okay, and compare them. And so we have a lot of confidence in our program on the quantitative nature of this. And if you really want to get quantitative and use this as an endpoint or to tell that you're doing well with therapy, you need to talk with your HLA lab person. So one of the things that we did, I told Matt, I said, Matt, let's look and see if reducing antibody changes the outcome. And so we just took a guess. 14 days was usually the end of a course of antibody-mediated rejection therapies. I said, so let's look at the antibody levels at 0 and 14 days. The other thing we decided to do was actually say 50% reduction is a good reduction. So it's just a number we picked, and that's very arbitrary. This endpoint of a reduction in the highest level of the DSA. So I've got 3 DSAs. This is the one with the highest MF5, okay? You get rid of it, all the others are going to be gone, okay? Reduction within 14 days. We didn't have any graft loss. And again, the numbers are small here. But look at all this graft loss you get if you don't do that. So we subsequently updated this, and with 89 patients treated with a bortezomib-based regimen, same regimen, right now today, if you have reduction of greater than 50% at 5 years, percent lower graft survival, about 40%. So in our program, we always want to see a reduction of at least 50%. Now, the next question was, does that hold for both early antibody-mediated rejection and late? And the answer is yes. That for both of them, if you achieve a 50% reduction within 14 days in your immunodominant antibody, you're going to have improved graft survival at 3 years. And it's about 30%. So that's one of the things that we try to achieve for all patients is a reduction in the donor-specific antibody. So this is actually data looking at Banff component scores. So this is an acute composite rejection score. So it adds up the I, T, the V, the PTC, and the G values and puts them together as a composite. So if your I scores 2, PTC scores 3, G scores 2, you add all of that up. And this is before treatment, and this is after treatment. And you can see there are statistically significant reductions using a bortezomib-based regimen for early antibody-mediated rejection, this is early AMR, this is early mixed, and this is late AMR and late mixed. For all of these, that works. So we also the other goal that we have in therapy is to minimize the inflammation in the graft, particularly the microvascular inflammation when it's an AMR. So creatinine, here are the changes in creatinine at 0, 14, 30, and 90 days. For early AMR, you can see there's statistically significant reduction at 30 days with a bortezomib-based regimen. For early mixed, same thing. But for late, improvements in creatinine, you can't expect. Okay, so those are our three endpoints. When we don't meet those, I usually go to additional therapy. So we look at the graph, we look at all these endpoints. If we don't achieve them with the first go round of therapy, we go to something else. Well, let's talk about some new agents. Dave mentioned these. Imlifidase, this is the streptococcal digestive enzyme that's been championed by a number of people. As you know, people like Bob Montgomery and Stan Jordan have used this. They've been some of the leaders in the clinical trials. But the first thing I want to do is I want to give you background on desensitization historically and talk a little bit about it. Basically showed was that if you desensitize patients with IVIG and plasmapheresis and then transplant them, they do better than if you leave them on dialysis and don't transplant them. Or they do actually do better if you leave them on dialysis and eventually get a matched kidney. So desensitization. So these patients here have a positive cytotoxic crossmatch. That means they have an antibody at least at 8,000 MFI. So these are the highest barriers to cross. This group has a negative cytotoxic crossmatch, but a positive flow. These are generally patients with antibodies at an MFI of 5 to high enough to give a cytotoxic. And these are patients that have lower level antibodies, not high enough to give you a positive flow. So they're generally less than 4,000. Okay, so you're trying to cross high level antibodies here. There is a 10% death rate. So you do not have that 10% death rate with the lower levels of antibodies, positive flow or positive Luminex. This is what drove everybody in the field. When this happened, Hopkins went on probation with Medicare because their patient survival wasn't good enough. So they quit doing it. They quit doing it. Everybody else in the field in the United States quit doing it. So this is what drove people to quit using plasmapheresis and IVIG in the presence of high levels of antibody. So that left us with desensitization only for the easy patients. The difficult, extremely sensitized patients have had no option for a long time. Well, let's talk about how those patients do with imlifidase, because that's the only thing that really matters, right? So this is a paper I refer you to. It's outcomes at 3 years post-transplant. It takes 39 patients from 4 single-arm open-label phase 2 studies. And these are the studies here. Now, I'm going to show you the data, and I'm going to separate out at the end the really high-risk patient data. So overall patient survival in these 39 patients treated with imlifidase. Let me just back up for a second. So imlifidase, you give it, and within 6 hours, all of the antibody in your circulation is cleaved. Okay, it's digested. And the way you get rid of it is you get rid of it through the kidney. You pee it out through the urine. Okay. So you've got a massive digestion of grams of immunoglobulin all of a sudden pouring into your kidney. So that's an issue to remember. There is high DGF rates and these higher DGF rates when you do this type of approach. Anyway, overall patient survival, 90%. At 3 years, 90% at 1 year. So there's a 10% death rate here. Remember what that death rate was? Patient survival, if they had an antibody-mediated rejection, the patient survival was 85%. Now you're going to see the antibody-mediated rejection rates in this group was 40%. So 40% of the patients going into this trial had an 85%, 15% death risk at 1 year. Here's your graft survival. So this is death-censored graft survival. On top of the 10 to 15% patient death rate, you have a 15% graft loss rate. So the rate of patients with a functioning graft and alive at 1 year is 70%. In these 40 patients treated with imlifidase, okay? AMR rates at 1 year, are almost 40%. So these are not easy AMRs. Some of them are really vigorous, scary AMRs that can threaten the life of the patient. Not all of them, but some of them. Renal function. Renal function is a little disappointing. It's about 50% at 50 mLs per minute at 1 year. But the important thing is to look at the spaghetti plots. Here's a group of patients that aren't doing very well. Those kidneys have taken a hit. So the question is, what kind of hit do they take? And here's the effect of AMR on renal function. You have about a 15 ml per minute loss in GFR if you have AMR. Okay. And this is what happens with the immunodominant donor-specific antibodies in patients with AMR and patients without AMR. And this is post-transplant. You can see a lot of these antibodies, class 2 in particular, persist over time. So you're digesting them, you're getting rid of them all, but they rebound. And it is that rebounding antibody at 7 to 14 days that's driving the AMR that you see here. Well, what about the worst of the worst patients? The patients, so what has happened, I don't know if any of you know this, but this drove us out of the desensitization. Since everybody in the United States with CPR rate 99.5 now doesn't have an increased waiting time because we allocate kidneys preferentially, nobody with a CPR rate of 99.5 can go into the desensitization program in the United States. Really smart, right? Thank you. So let's look at the group that's 99.9%. So your chances of getting a kidney here are 1 in 1,000. So 1 in every 1,000 donors will match you. Okay. Patient survival, 1 year, 75%. You have a 25% death rate in this population. Graft loss on top of that is another 10%. The AMR rate is over 60% at 1 year. So there's over half of these patients will have a significant AMR. Here's your GFR. It's actually not too bad, but there are some patients down here that are going to go on to lose their graft fairly soon, probably. And here's long-term persistence of class 2 DSA. So adding all this up, in CPR, high CPR patients, 22% death, 8% graft loss, almost 60% AMR. So the worst of the worst patients, the ones that need this the most, have unacceptably high rates of death and graft loss. Okay. I would submit to you that, you know, in the US, if you have a CPRA of 2 to 3,000 or less, you're going to get transplanted with a deceased donor kidney. And so the point is that even with imlifidase, you've got to pick and choose which barriers you're going to go across. This is not a cure-all. Now, when we're able to control the rebound antibody using modern pharmacologic agents, and we understand the mechanism by which that rebound antibody occurs, these numbers may change. And that's what imlifidase needs, is a method to control the rebound following the complete digestion of antibody. And this is Professor Pando Regal's data from his paper. If any of you haven't read this paper, you need to read it so that you understand what precision PRAs tell you. If you get a PRA that's a 6-digit PRA, it will tell you whether or not you can use calculations that you put in this paper to tell you whether their chances of being transplanted are 1 in 1,000, 1 in a million. You just do a reciprocal function calculation on it. But these 9% PRA or higher. As you can see, there's probably somewhere around 2,000 patients total in the United States with a CPRA that high. So this is the level of patients, number of patients that we're talking about. The problem is these patients, once they go on the list, they tend to stay there. So that's why their proportion. Well, many of you are already aware about bortezomib. I'm not going to talk about it. It's been out for a long period of time. Suffice it to say, in our hands, for treating AMR, it can do just as well as IVIG. And for desensitization, it did a pretty. previously for IVIG-based regimens, but we couldn't get it as good as we wanted it to be because we were dose limited by toxicity. So we went to another drug called carfilzomib, and we showed in desensitization that carfilzomib is superior to bortezomib. So the question is, how does carfilzomib do for antibody-mediated rejection? There's only one paper out there in kidney. I think a couple of them. We published this one, so I helped my colleagues at Cincinnati Children's treat 2 patients with carfilzomib. And the bottom line is that it drops antibodies very efficiently. Okay, you're treating plasmablasts here. So when you have an acute rejection, what happens is you generate new plasmablasts. So they're new plasma cells, newly formed, that are generating large amounts of antibody. Those plasmablasts will not survive more than 24 to 48 hours if they don't get into a bone marrow niche, a survival niche in the bone marrow. So if you catch them in transit, they will die like smelts. When you just got to wave the bortezomib under the patient's nose, okay, and they'll die. The cells that are more difficult to treat are the niche resident long-lived plasma cells. So plasma cells that aren't new, but have been in the patient for maybe years due to a pregnancy or a blood transfusion many, many years ago. And so that's why we use desensitization and not AMR, because we know we can treat AMR. It's easy to treat. It's driven by plasmablasts. Desensitization are long-lived antibodies that patients had for a long period of time. And what you're trying to get rid of there are long-lived niche resident plasma cells, okay? So, and carfilzomib is superior for that. Well, let's talk about anti-CD30. First used bortezomib, and then we went to the second generation. The one thing I do have to tell you is you get nephrotoxicity, and we saw nephrotoxicity in these patients. One patient was worse than the other. The way you get rid of that is that you put the carfilzomib, instead of an IV push, you put it in a 250 mLs of D5W and infuse it over about an hour at least. And that will substantially mitigate the acute kidney injury that you get with it. It has to be shown and further out, but in speaking with the company, the guy that invented the drug, and that's what we've done in one of the patients there at Cincinnati Children's. So other thing people started doing, us and others started looking at other ways to target plasma cells. One of the ways is actually use antibodies. Now, these anti-plasma cell antibodies are being developed to treat multiple myeloma. Multiple myeloma has had about 10 drugs FDA approved in the last decade. It is a target-rich environment. So this is daratumumab. It binds to CD38. CD38 is a marker that's present on activated B cells. It's also present on new plasmablasts and also on plasma cells. It's also present on Tregs. Okay, so whenever you give this drug, you're depleting Tregs. So there are 3 case reports here of its use. Stan Jordan reported it. This was a patient who had severe ABMR, resistant plasma exchange, IVIG, retux, and complement inhibition, basically the kitchen sink at Cedars-Sinai. 4 weekly doses got rid of this really bad AMR, about as bad as they come, but was followed 4 weeks later by severe T-cell mediated rejection. Okay. And so clearly daratumumab reduces antibody levels and allows improvement of function and resolution, but there's this specter hanging. So actually in a paper, so Gene Kwan and Stuart Connectley, we've talked with them. They're part of our plasma cell therapies group. We talked to them for a long time. They actually did 8 primates with daratumumab. They also did it in combination with plerixafor, but plerixafor is part of AMR. And they saw primates and these 2 humans that both had severe T-cell mediated rejection following daratumumab. Okay, so it's real. It is unclear, this is from their paper, quote, It is unclear why treating sensitized non-human primates with daratumumab DSA levels. We cannot attribute this to animal numbers. It is possible proximity to sensitization events, No, what it is you're depleting Tregs. Okay. And so we've actually shown that Tregs are depleted in our studies. Is a good way to go. I think there's other targets on plasma cells. And we'll talk about one of those now. So CAR T cells, who all knows, who all's heard of CAR T cells? Okay, good. I'll explain what they are. CAR T cells are all the rage in oncology now. So what you do with a CAR T cell is you repeat cell as to what kind of cell it's going to kill. Okay. The way you do that is the T cell receptor that sits on a T cell. So each T cell has one unique T cell receptor. All right. The way you make T cell receptors is you rearrange some genes. And by rearranging those genes, you can make over 1 billion different T cells. So each one of us here in this audience has the ability to make up 1 billion different T cells with a unique T cell receptor. Now, if that T cell clones itself and makes 100 copies, then that becomes a T cell clone, right? Okay, so what CAR T cells do is they take the T cell receptor and they make a synthetic one. What they do is they take an antibody and they cleave out the two tips of it, where the specificity of that antibody is. So we're going to want to target leukemia that has CD19 on it. Okay, so most B cells have CD19, so that's kind of a good thing to target. So you cleave out the two variable regions, you put them into a single chain antibody so that they fold and recapitulate the antibody. And then you put them on a cytoplasmic tail that has a lot of phosphorylation motifs, so that when that CD19 is engaged right here, when this two FV fragments from the antibody engage CD19, a tremendous activation signal is transmitted within that cell. Now, you could take any antibody that's ever been made, cleave out the light variable and the heavy chain variable regions, and make a CAR. Wow, right? Then you give these cells with an antibody, it may deplete, may not deplete, depending on its chemistry and its FC receptor region. But you put it on this, and you're going to have cells floating around for a long time. The other thing is that these cells, a lot of times in patients, in 4 weeks, it's gone. These CAR T cells, depending on the dose you give, they may be around for a long time. So Ali Naji at Penn works at Penn. St. Jude's that developed CAR T cells. There's a big battle over the patent. There's going to be a big battle over the Nobel Prize too, when that's given in about 5 to 10 years for this. But suffice it to say that because Carl is there, Ali Naji went and talked to his group and said, hey, we'd like to use these to target plasma cells in humans, normal plasma cells. Okay. So so what you do is you take blood from a patient, take their T cells out, you make a gene. That's the gene for the CAR T cell. You transfect those cells with the gene, you expand them, and then you give them back to the patient. So you're giving literally millions of these targeted cells back. There's 6 now. There are 6 CAR T cell therapies that are approved by the FDA. 4 of them target CD19, which, is the same target for rituximab, right? So you could basically take Ritux, take the variable regions, put them onto, and make a CAR with it, right? But this is a really interesting antigen that Ali is intending to do with his NIH funding through CTOT. BCMA is an antigen that's present on plasma cells, and is present on it may vary somewhat, 70 to 80% of plasma cells. So by using this CAR T cell, you may be able to deplete up to 80% of your plasma cells for a prolonged period of time. Okay, and that's sort of the theme and the way they want to go about this. Okay. All right, now I want to move on and talk about a very interesting area that has not been used in transplantation yet, but Stan Jordan wants to do this. We've made phone calls. A lot of people are making phone calls. It's just a matter of time for some company somewhere will invest the money to use this drug in transplantation. Why so the neonatal FC receptor is present in lots of tissues. One of the most famous places where it's present is in the placenta. So, you know, when newborns are born, they have no immune system, right? They have no well-developed immune system at all. What they're protected by are mom's antibodies. Through the neonatal FC receptor. So what this receptor does is it sits on one side of the placenta with maternal blood, it extracts an antibody, and then it transgresses across that cell and it releases it into the child's circulation, to the baby's circulation. So these babies will have mom's IG hanging around for they will get some antibodies through breast milk. You feed them formula, they're not going to have it, right? That's one of the cool things about breast milk. But here's your two receptors, FC receptors, and here's an immunoglobulin molecule. Here's the FC portion, here's the FAB portions, and this is basically how it binds it, and then it gets internalized and it gets released on the other side. So this is sort of a cartoon. Here you've got antibodies. They bind to the neonatal FC receptor. The neonatal FC receptor with the bound antibody is now in an endocytic vesicle. If the antibody is not bound, it gets degraded. If it is bound, it gets recycled and released. So this is the way you keep your antibodies in the circulation. You wipe out this recycling and your antibodies are degraded much, much faster. Okay? So people are now targeting and developing agents specifically to target and block the ability of the neonatal FC receptor to bind these antibodies. Okay? We've already talked about that. So there are 5 antibody-based drugs that have demonstrated ability to reduce circulating IG by binding FC receptor. In December, 2 years ago, less than 2 years ago, the first blocker was approved. This drug is all the rage in myasthenia gravis. It has radically changed the course of myasthenia gravis. You get a patient that comes in the hospital with anti-acetylcholine receptor antibodies, and they're having to be put on a ventilator, give them this drug, a couple of days later, they're off the ventilator, back home. That's miraculous. So it's radically changing that disease. Here's another one, second one that has now received FDA approval. The other conditions are ITP, idiopathic thrombocytic purpura, that's mediated by antiplatelet antibodies. Another one is pemphigus, a condition where you get a lot of skin lesions and boils basically in your skin. So the adverse events are minimal. Headache's the worst thing that happens when you get one of these drugs. But the bad news is, and this is what's going to be dose limiting, is that every antibody you have is going to go down. So it's going to induce hypogammaglobulinemia in the patient, okay? Lixizumab, the antibody is recently approved. This is the levels of acetylcholine receptor antibodies in myasthenia gravis patients. And you can see here, literally within the first week, 20 to 40% reductions in the total level of their acetylcholine receptor antibodies, okay? And then you look here, by the time they get to a more steady state, 60. Now, there are drugs that can give you an 80% reduction in antibody levels within 7 days. Single dose of an antibody and 80% of the antibody in your circulation is gone. Now, think about how that would do in an antibody-mediated rejection patient. That's better than plasmapheresis. No side effects, no central catheter, none of that. You got to have a lot of money for this, though, because these drugs are really expensive. But you can see there's a dose-dependent response. When you go from 4 to 7, you get, and they haven't even topped out and maxed out here in this one. But here's what happens to your serum IG. Exact same thing. Just as the pathogenic antibody goes down, down goes all your other antibodies, okay? So how do you manage that? One thing you could do is throw IVIG at it, but it's going to get clear from circulation as fast as everything else. You can revaccinate patients. Once it comes off, as you can see, the antibodies come off pretty quickly. Now, one of the things, if you got into problem with infections, you could pherese this antibody off pretty quickly. Okay, so what about IL-6 blockade? Well, I'm not going to go in a whole lot into it. I want to just summarize. So these are a few of the papers that are out there. I think the real big issue with IL-6 blockade, whether it's blocking the IL-6 cytokine or blocking the IL-6 receptor, the clazakizumab trial is going to be sort of the end-all, see-all. It's a big trial. It's looking at standard of care versus standard of care plus IL-6 add-on. And looking at outcomes and late sort of smoldering acute antibody-mediated rejection. Most of them are add-ons, just add-on tocilizumab. So there is what you see is you actually see graft survival usually around 70 to 90%. After you've added on tocilizumab for these particular patients, you see reduction in the DSA levels. It's modest, but it's real, okay? You see improvements in inflammation, whether it's microvascular, but also in interstitial inflammation. IL-6 is a very potent cytokine. At every stage of maturation in a B cell, whether it's in the bone marrow or whether it's out in the lymph nodes, those cells need IL-6 to survive each. Once you get to a plasma cell, you don't need IL-6. You need IL-6 to become a plasma cell, but you don't need IL-6 once you get into the marrow, okay? So by knocking out and inhibiting that, you do get some reductions, modest reductions in antibody levels. Now, something that's less recognized is that T cells, IL-6 is a very potent growth factor for T cells. It's also involved in innate immunity. So you're broadly inhibiting immunity, both T cell, B cell, and innate immunity when you give IL-6. Because of that, one of the problems has been an infectious signal. So you can see here, both viral, bacterial, fungal infections are at risk here. So one of the questions is going to be is how do you balance adding on an IL-6, which is a fairly potent immunosuppressive agent, with standard maintenance immunosuppression? Stan Jordan has admitted that there are some patients that he's had to reduce concomitant immunosuppression. Usually it's MMF, but really the fine tuning on this is going to be when you add it on, what do you subtract? And what's the optimal way to treat these patients? So that's going to be, it's going to be a learning curve. And it's not going to be an easy one, but that's and what we've been doing, the way we view cellular rejection. So the 2A and 2Bs and the graft loss, what's the lesion? This is the lesion driving it. This is endotheliitis. See all these little cells here? Those are T cells. If we know how to target those T cells, guess we have to learn how to target these that are over here also at the same time. And then there's some that are actually invading tubules, causing tubulitis. So wouldn't it be cool to be able to know what this cell's doing, what the gene expression is in that particular cell that's in that particular lesion? So most of the studies, in the early studies, and all of Phil Halloran's studies have done today, they use basically microarray and bulk RNA sequencing. And what they do is they take it from the kidney from the biopsy and they elute it and pull it out of the entire biopsy. That kind of gives you a kind of a milkshake here because you've got messenger RNA being derived from all different kinds of cells, right? You don't know what kind of cell it's coming from. Well, there's a new technique that has been around for about 10 years. It was first developed 10 years ago, but it is radically changing our understanding of almost every inflammatory disease, and that's called single-cell transcriptomics. What single-cell transcriptomics does is you take tissue, and the first generation of this, and we'll talk about a different approach later on. You digest the kidney biopsy, you release all of the individual cells in that biopsy, They're then in a microfluidic chamber. They're encased in an oil droplet with these little tiny beads. And the little tiny beads have poly A tails that captures all your messenger RNA. And they label it so that you can then track back that RNA to which cell it came from. So this looks at gene expression, total gene expression from thousands of cells. So it's looking at thousands of genes in thousands of cells. The amount of data derived from this requires some big time computing power. Now, and you have to go through a bunch of steps to do it, but the big thing at the end is the bioinformatics. How do you, and so there are tools that are present now. So now what you do, instead So this is a paper we just published, the first characterization of human renal allograft rejection in 10 patients on varying types of immunosuppression, and defined this by single cell genomics. Tiffany She's an MD PhD student. Dave Hildeman is my partner, who's a wonderful, talented immunologist. RNA-seq. Each dot on there is an individual cell. Where it sits on here depends on the kinds of genes and the amount of gene expression it has. So the closer one dot is to the other dot, the closer that they are. They're probably from the same place in tissue. So notice right here, these are all derived from the nephron. Here are proximal tubular cells. You know, there's 3 populations of proximal tubular cells in the nephron, right? Y'all know that? The first one is the one that gobbles up all of the protein and is really highly metabolically active. And then you have the second proximal tubule and the third one. Here's the thick ascending limb. Here's endothelium. Here's podocytes. So now from a kidney biopsy, I can say what genes are turned on in podocytes, right? If you think that this is a risk for antibody-mediated rejection and you want to know, are the podocytes being injured? Now you can look at the podocytes. Distal tubule, collecting ducts. These are all inflammatory cells. See up here? CD4, CD8s, gamma delta, B cells, myeloid cells. It's 3 different populations of CD8s at least. So here's your nephron, and this is our young faculty member, Tim Caldwell. And his job right now, since he's a nephrologist and knows a lot about all the cells in the nephron, he is asking the question, can you recapitulate the BAMF based on the amount of injury to individual cell populations within the nephron? And the answer is yes, and we think it's better. So no longer will you just look at the infiltrate. You know, with BAMF, you look at the infiltrates, right? How much interstitial inflammation do you have? How much endotheliitis do you have? Okay. How much tubulitis do you have? Now with this, you'll be able to transcriptomically go in and look at proximal tubular epithelium, which is the primary target for a cellular rejection, and be able to tell what the BAMF criteria is, because you'll know how injured the cell is. It doesn't matter how many inflammatory cells are. What matters is how much injury those proximal tubular cells are getting, right? So anyway, so this is the types of populations. So in each one of these little dots, you know thousands of genes. So immune cells. So this is our 4 patients that didn't have rejection. All of their cells are derived from the tubule and the nephron. When they have rejection, look at all these extra cells. What are these? Well, these are the CD8, CD4s, B cells, and myeloid cells driving the rejection. Okay. Now, let's just take the CD8 T cells that are in the graft. There are at least 8 populations here. So this is 10 index rejection biopsies, 10 different patients. 4 of them are on tacrolimus, 3 of them are on belatacept, and 3 of them are on an anti-CD40 blocker drug called iscalimab. These are individual enzymes that are activation markers. This is perforin, this is granzyme, this is Ki67, which is a proliferation marker, which identifies this proliferated group of cells. These are exhaustion markers. So when a T cell is constantly stimulated for a long period of time through its T cell receptor, it eventually becomes exhausted. When it becomes exhausted, it expresses things like PD1, LAG3, TIGIT. And that just means it's been there for a long time, but it gets tired. It can't produce cytokines. It's not going to kill as efficiently. So it's important to know whether these CD8s are activated or exhausted. And then here's a memory profile with individual markers that are memory cell markers. Now, the other thing that we did, and Dave came up with this, is when you sequence, normally you go 5' to 3'. When you're making these messenger RNA and cDNA libraries, but the T cell receptor message is down at the end. So being able to tell what T cell receptor each T cell has and whether it's unique, we did by using a 5' kit that's now available. Okay, so not only effector memory or whatever, we now know the exact sequence of its T cell receptor. So now we're getting information on thousands of different T cells. And the question is, in the graft, are there expanded CD8 clones that are expanded because we know they're expanded because they express the same T cell receptor? Okay. This whole pie, these are 4 rejection samples from tacrolimus, 3 from mescalimab, 3 from belatacept. The gray part of the pie are T cell receptors that are not expanded. These sliced colored parts are expanded T cell populations. These are the cells dividing and multiplying in the graft because they're responding to HLA antigen. They're driving the rejection. In this patient, there were only 3 different populations of T cells with a unique T cell receptor driving that rejection. You wipe out these 3 T cells, you don't have any rejection. Now, in this patient, there were 120 different clonotypes that were expanded. There was a total of 1,400 different TCRs, TCR clones, individual clones, and only 120 of them were expanded. Okay. Here, this patient had 511 different T cell clones in his graft, of which only 32 were expanded. All right. So this is giving you an idea. There's only a very small number of expanded T cell clones that use a very limited number of T cell receptors to drive these rejections. And those are the cells you need to target. So we don't care about any of these cells. Just get rid of these, and you've gotten rid of the rejection. Easier said than done. So this is actually, remember the same sort of dinosaur-looking plot we had with the CD8s? The ones that are in color here are expanded. The ones that are in gray are unexpanded. This is what it looks like with tacrolimus. Was that the nature of the T cell populations driving rejection should be different if a rejection appears under a different immunosuppressive agent. This is the first data to ever show that hypothesis is true. So memory B cell populations were driving the belatacept. These proliferating T cells down here, nothing. Look at iscalimab. It's largely driven by exhausted cell populations. Why are they exhausted? Because their T cells are being chronically stimulated, because they're not on a calcineurin inhibitor. So they got constant T cell receptor driven signals going to the nucleus. Guess what? When we ask the question, what are the genes that are upregulated, these iscalimab, FK binding protein, the receptor for tacrolimus, was upregulated. So I empirically had treated these patients with tacrolimus because they weren't on it. They had rejection. We knew tacrolimus is a great drug for rejection, and it worked beautifully. To treat rejection of iscalimab, you don't need steroids. You don't need thymoglobulin. That's the power of this, is it can tell you what are the cells driving the rejection, what is their gene expression. Then you can go pick an individual drug and specifically target those cells. First time you can do patient-specific immunosuppression. Now, this is belatacept cells. Those cells are markedly expressing mTOR pathway moieties. No expression in iscalimab. This blue means there's hardly any expression. Red is hot. Little bit intact, but mTOR is a drug. We've already previously shown that through other studies. So the neat thing I'm going to tell you now is these T cell clones are in the urine. Why are they in the urine? Because when a T cell goes to attack a tubule, it crosses the basement membrane, right? Then it nukes, sloughs, And guess what sloughs off in the urine along with that cell? The T cell that killed it. So when you look at the clones, the T cell clones that were driving the rejection in the biopsy, they're also present in the urine. These are called clonograms. So this is a patient underwent, I biopsied him 4 times during rejection because he didn't really respond. Or the expanded clones. And you can see between when you give steroids in the first round, didn't help at all. The clones expanded, got worse. Then we gave some ATG, got better. But then we biopsied him 100 days later after no therapy. And look at this. All of a sudden, a brand new clone is here, right? You've got a brand new, so the clones don't stay. The ones you start with, they're going to expand and contract, and many of them won't go away, but then you may have new ones be developed. So rejection's an ongoing living process. It's dynamic. What cells are driving the rejection in the beginning may not be the cells driving the rejection 100 days later. Okay, so one of the ways that we proved, so one of the things we had to prove was these expanded CD8s, that their T cell receptors were indeed recognizing antigen. So we took the T cell receptor from 5 expanded clones in one patient that had rejection. We transfected them into Jurkat cells, which are T cells that didn't have T cell receptors. We then mixed those TCR transgenic cells with cells from the donor, and they produced a ton of IL-2. The non-expanded clones from that patient, we took 5 non-expanded clones, they didn't produce IL-2. What does that tell you? They're responding to donor HLA. So indeed, these are the cells driving the rejection. So wouldn't it be cool if you could actually take a biopsy and look at that cell that's attacking this tubule and know what its gene expression is? Well, that technique is going to be possible with spatial. You can now do this without tissue rejection, without tissue digestion. You could take a pathology slide, fixed formalin slide that you look at, and now do thousands of genes and thousands of cells sitting in the tissue. It's not quite ready for prime time, but this is what's going to happen. Just looking at this, you're going to be asking the pathologist, what kind of cell is that? What genes does it express? And then you're going to get a list and you're going to pick out what drug you're going to target it with. This is just around the corner. So these clones, they morph, they change, they cloak and dagger is what this is all about. Here's a patient with a 1B rejection treated with TAC and steroids. Here are, in color, are the expanded CD8 clones. They have an activated effector memory profile, okay? We treat them with steroids, it stays at a 1B, and the cells actually expand. They've gotten worse, okay? And there's actually some newer ones in here. See these green ones? Then they got MMF. Now, this is a patient that actually had a little borderline borderline BK, so I didn't want to hit them with thymo, right? So we added MMF. They completely changed their profile from an activated to an exhausted profile. The rejection improves to a borderline, okay? We do nothing else. 100 days later, look how these T cells have changed. They're still there, but now there's a resident memory phenotype, a phenotype that immunologists are now thinking this may be a type of T cell that's refractory to treatment. So we've been able to follow these clones, and they change. They change their gene expression. They adapt. When you throw steroids at them, the ones that don't die, they adapt so that steroids won't ding them again, okay? So this is a dynamic population of cells that changes its phenotype and based on what you do to the patient. This is a patient, similar type of thing. Here's all of his activated effector expanded cells, rabbit ATG and steroids, thymo, and guess what? Despite the fact you've given the very best, lot of persistence here. These cells also have morphed. They've changed their phenotype. They're now resident memory phenotype. This was a borderline rejection. The patient had actually started to have a CMV viral load, so we elected not to treat anymore. Repeat the biopsy 70 days later, no rejection. Okay, fine, we got it, we're taken care of. These cells still exist. The cells that drove the rejection are still in the graft. And it's not just a few of them, it's enough of them. 100 days later, this patient came in with a rip-roaring rejection. These same cells were in the kidney driving the rejection. Patient lost their graft. Major problem. So this is spatial transcriptomics. This is actually an entire mouse kidney. Here you're querying CD31, CD8, CD4. You can see what cells pop up. This is what we're going to be seeing. We're going to be taking pieces of human tissue and knowing what genes are being expressed. Not only that, but there's another thing, and I want to explain this to you. Sometimes the gene's only turned on for 15 minutes or so. Sometimes the messenger RNA only lasts for an hour or so. So you may biopsy and you may miss a fourth of the genes. Well, one of the ways you can go back is you can go back and ask, is the DNA for that gene open for transcription? So what happens is when you get ready to make messenger RNA, the DNA unwinds and exposes so that the RNA transcription complex can come in and transcribe the gene, right? So open chromatin is essentially an area of DNA that has been transcribed or is ready for transcription. Well, guess what? There's a thing now, it's called single cell ATAC-seq. And what it does in each individual cell, it tells you every gene of 40,000, every piece of gene DNA in 40,000 genes that's open for transcription in each individual cell. And you could do that on the same biopsy. Can you imagine the power of that? Now, so this is actually the readout from an ATAC-seq, basically showing in CD8 naive T cells, CD8 memory cells, other types of cells, which chromatin is open, which genes are open. And it does that for the whole genome in each individual cell. Talk about powerful. These are the technologies that are being brought to bear upon many disease states, and they're being brought to bear by us and other folks in transplantation right now. Up to blow your mind. This is the messenger RNA that we look at. This is the open reading frames in DNA that we look at. But there's even tests that you can do beyond that. Not only can we tell if the DNA is open for transcription, but we could tell you with single cell ATAC-seq and single cell ChIP-seq what transcription factors are actually bound to that open chromatin. So transcription factors, as you know, is what drives the initiation of a gene expression. So by knowing DNA methylation, transcription factor binding by ChIP-seq, single cell ATAC-seq, and single cell RNA-seq, now we're looking at an entire network of gene regulation on top of all the rest of that. This is what we're going to be targeting for new drugs in the next 5 to 10 years. Our gene regulatory networks that are acting sort of behind the scenes under the cover that are driving the activation of multiple genes during a rejection process. And we'll know that for each individual cell that's sitting in a graft. It's going to cost some money. So in the future, when we sit down, we're going to be asking the pathologist, what kind of cells are these? What genes are they expressing? We may even know we'll know their open chromatin, and we'll know the transcription factors and the gene regulatory networks that are driving expression of thousands or hundreds of genes. So in conclusion, many rejections have both cellular and antibody components. We have hypothesized that improved rejection outcomes, both ACR and the AMR, must be specifically and effectively and completely treated. We need new endpoints for AMR and ACR. And I think as we move forward with these newer techniques, we're going to have new endpoints. Expanded CD8 clones, that's what's driving rejection. They persist even when you think the rejection is gone. Why, when you give the most complex vaccine that you could possibly give to you, you should have thousands, if not millions, of different T cells driving these. But no, some patients only have 3 different types of T cells. There is a basic immunologic function that is driving that, that's behind that. And we need to understand that. And when we do, then maybe we'll be better at being able to effectively prevent rejection. New CD8 populations may appear during treatment. Individual CD8 populations may expand or contract during treatment. These CD8s express distinct phenotypes based on the type of immunosuppression. They demonstrate plasticity and they adapt in response to therapies. This is a dynamic process that we're just beginning to understand. More importantly, we can now get to personalized medicine where we can specifically target these populations based on therapies that are derived from the types of genes that they're expressing. In AMR, DSA is the greatest. It's the best criterion. We think lowering DSA should be, and clearing the inflammation need to be the number one, number two things we want to achieve. Anti-CD38 antibodies have the risk of Treg depletion and aggressive ACR. FC receptor blockade is ready. It may be problematic in terms that it causes hypogam, but and we'll know about IL-6 blockade very soon. With that, this is the lab. Tiffany's the one that did all the single cell work. That was her entire PhD thesis. And now she's actually going and characterizing the innate cells, the macrophages and monocytes. And we're starting to see that there's new types of monocytes that are involved, or macrophages that are involved in this. Dave Hildeman is my good friend. We've worked together for 10 years to complete this project. It only took 10 years to do that. And then Ashley took all the biopsies, consented all the patients. She's actually Anna Peters has done the same thing now in liver. We see the exact same thing in liver. Okay, so we're going to be able to have specific targets for liver. Don Hayes and Catherine Wiekenheiser are working on single cell. We're actually a little bit behind Pittsburgh. Pittsburgh is actually, their lung program is a little ahead of us in single cell genomics to define lung. Next guy really knows T cell receptors and B cell receptors. And Brian Baker at Notre Dame is a basic biologist who's helping us do what we call de-orphan a T cell receptor. In other words, you have a certain T cell receptor. How do you know what it's recognizing? Which HLA molecule, which peptide are these expanded CD? For the first time, what T cells are actively recognizing in these graphs. Thank you very much.
Thank you very much, Steve. Excellent talk. Very interesting. So, no sé si hay preguntas. Estamos muy cortos de tiempo, así que les voy a pedir una o dos preguntas no más.
Steve, thank you very much. That was fascinating. I'm anxiously awaiting the appearance of the JCI paper. There's just mind-blowing stuff. One of the papers that we published recently in AJT has exactly what you have just talked about, is the rejection that goes on and goes on and goes on and goes on and goes on. 50% of our patients reject when you look at them again, and they're still rejecting, and they're still rejecting. And I get it from what you said, that there is persistence, adaptation of the lymphocytes to what they're being fed, and they are actually counteracting what we are trying to do. And have you, or do you have any experience with, in experimental or otherwise, about changing immunosuppression at different time points to mitigate what is going on in a graph that is being rejected? Or has that been done systematically in any way in the past? Let's stop this, let's change completely our target, because there's something else going on, obviously.
You know, he's got this idea that rejections are incompletely treated, and that's what's driving the graft loss. We've thought that for many years. In fact, when Peter's done a really nice literature review on rejection treatment, and one of the papers he picked up was a paper that we did back with TAC Rescue in the mid-90s, where we did protocol bio first week, 60% of them are resolved. Second week, another 20% are resolved. 3 weeks, another 10%. And then there were still some persisting at 4 weeks. And it's one of the few studies where there's been a protocol-based biopsy at weekly intervals during an entire course of rejection. What we do, and what a lot of inflammation left at the end, if it still meets rejection criteria, people will probably throw steroids again or something else. They may throw IVIG, but really we're at a loss to understand that. And second of all, most people don't rebiopsy enough. If you're religious about it, we've sort of try to get rid of it. Now, the one point where I don't try to get rid of inflammation is when it's in IFTA, because that's in the scar. If I've got active inflammation with a tubule, we'll continue to treat that. It may be that IFTA needs to be treated. I don't know. I mean, this is what's really kind of crazy. And another thing is that's where spatial. If they're in IFTA, that may not mean as much as targeting the T cell clones that are in an active tubulitis or endotheliitis lesion. And so that's why I think we've got to get to spatial at some point. We actually want to, there's about 3 or 4 platforms for spatial right now. They're being developed by companies. The problem is that you need to get it down to where your resolution is at the diameter of a cell. It's got to be like, 10 microns or so. And now they're at about 3 cells. A lot of these platforms can get you down. So you don't know if the gene expression is in any one of 3 cells, but it's going to get there. It'll take time. But I think it's a very astute point that the field needs to come around to understand you need to treat a rejection to the end. And what to that end to me now is when there's no tubulitis and no endotheliitis. There could be residual inflammation, but if it's in areas of IFTA, I don't worry so much. I'd like to clear the interstitial inflammation, but then you got to balance that against how much immunosuppression you're throwing at them. Are there CMV viral loads popping up? But I think this is a subset of patients. If you look at rejection, you have 8% of patients reject at 1 year. And 4 of those, half of those are non-compliance. Patients are non-compliant. But after that, it's about 1% per year. And those late rejections are the ones that are really ugly, as you know.
Steve, just short question. Have you done the same work with infection rather than rejection? Do you have the same pattern?
Yeah, we don't know. I mean, we haven't, so like with BK, so we're starting to apply this, and we just took 10 BK biopsy samples last week and did single cell genomics on them. And so we're in the process of doing the bioinformatics. That could take us several weeks. But yeah, we're trying to sort that out. So being able, I think actually this has a lot of promise for giving us some insight into how BK gets activated, what genes it's interfering with in the cell, and how the cell gets dysregulated, and maybe even starting to understand the T cell response to BK. What triggers that? As you know, many patients have BK and they have a little bit of inflammation here and there, and then all of a sudden you come in one day and they've got this huge inflammatory infiltrate, and you don't know if it's rejection or response to BK. You know how you can tell whether or not it's the T cells are recognized, whether it's a BK or a rejection. You have to know the specificity of the T cells receptors that are in there, and you have to deorphin. I mean, and so there's models, there are techniques now that can actually physically model a T cell receptor, and it's down to the angstrom level, and actually once we know what the some of the peptides and HLA antigens are, then we'll better know. We published that data with Igor Koralnik actually about 10 or 15 years ago, but now we've got to redo that with Brian Baker. So that's one of the reasons why we got Brian Baker. When T cells recognize an HLA antigen, their T cell receptor sits on a kind of side saddle. Amino acid. Or is it recognizing the peptide sitting in the groove? That's what you have to know. And that's the level of specificity we got to be able to, and we'll get to that, probably 5 to 10 years.
Simposio, y en esta sección del simposio vamos a presentar, en realidad van a presentar casos clínicos. El doctor Marcelo Pando, que lo presenté ayer en el simposio, que trabaja en Estados Unidos, es especialista en HLA, trabaja en Austin, en Baylor, y es asesor de varias de las universidades, por ejemplo, en la Mayo Clinic de Arizona y otras universidades. Y acá Santiago Sobrecasa, que es que todos lo conocen porque es de acá de Tucumán, ¿no es así? Así que vamos a dar comienzo entonces a los primeros casos clínicos, que empieza Marcelo, sigue Santiago y después le vamos a dar la palabra a Rafael, que anda por ahí.
Perfecto, acá está mi. A ver. ¿Así? ¿A dónde apunto? Ahí está. Bueno, vamos a empezar. Lo mío siempre es el HLA, no cambio. Así que les voy a mostrar, esto es para recordarles lo que les voy a seguir mostrando en las próximas slides. Principalmente este es el test que usamos corrientemente para detectar las especificidades de los anticuerpos contra HLA. Entonces, esto es lo que vemos. El programa se llama Fusion y generalmente tenemos un histograma donde podemos ver cada una de las bits como una barra en el histograma. La fuerza del anticuerpo va a estar dada, a ver si tengo el puntero, perfecto, por el tamaño de la barra, y los colores muestran qué tan fuerte es el anticuerpo. En este caso, estos anticuerpos a la izquierda son muy altos, de 9000 MFI. El test llega hasta 30.000 de MFI, o sea, y obviamente hay anticuerpos muchísimo más grandes, más altos. Y acá tenemos las especificidades de los anticuerpos, o sea, en este caso un B53, un A1, A24, etc. Pero eso es para que entiendan el test que realizamos, cómo lo miramos, y por ejemplo en este paciente tenemos un montón de especificidades de HLA-B, un montón de especificidad de HLA-A, y esto probablemente dé un PRA muy alto y se considera un paciente altamente sensibilizado. Bueno, el caso 1, este es un caso clásico, es un caso viejo que tuvimos en la clínica Mayo, pero me parece que es un caso importante de evaluar y ver los resultados. Y como dijo acá la colega, está relacionado con animarse, ¿no? Y sigamos. Bueno, esta era una mujer de 40 años con diabetes de tipo 1, con enfermedad renal. Este era el PRA era casi completamente negativo. El PRA, para recordarles, es otro test de Luminex, que en vez de tener lo que llamamos single antigen bits, que es lo que les mostré recién con un antígeno por perlita, en este test es un poco más broad, que
que reconoce muchos más antígenos y fenotipos que el single antigen bit. En el single antigen bit le mostré que tenemos una bit que es para detectar B53. Acá tenemos bits que tienen el fenotipo de una célula, o sea, todos los 2A, los 2B y los C. Entonces, principalmente este test sirve para hacer un screening, además es más barato. Ustedes saben que el single antigen bit es muy caro. Este es bastante más barato y esto es para hacer un screening antes de empezar a hacer el single antigen bit y ver qué tan sensibilizado está el paciente. Esta paciente entonces tenía 0 para clase 1 y 0 para clase 2, así que muy bien. Hicimos el single antigen bit, esto es en la clínica Mayo, o sea que le hacen cuánto test se le puede hacer. Y tenía anticuerpos contra CW4 con un MFI entre 3.000 y 8.000, o sea, intermedio, no muy alto tampoco, y es C, que está generalmente a menos densidad en las células, y después teníamos un CW18, y esto nunca se sabe si es background, si es pegado inespecífico o qué. Pero bueno, esos dos los detectamos en esta muestra. Si vamos a otras muestras, detectamos otros anticuerpos como A11, alelo específico, A25, ciertos B, ciertos otros C, pero el CW4 aparecía en otras muestras, o sea, eso era algo constante. Clase 2, completamente negativo. Y acá otra muestra similar, el CW4 y el A23, 24, 25, un poco más de especificidad desde acá. Esto era septiembre de 2014. Acá tuvimos una oferta de un donante, corrimos el crossmatch con la muestra de octubre 6, que fue el día del trasplante. El crossmatch fue completamente negativo. Había un DSA a nivel muy bajo, A24, 1049, y ese DSA no lo detectamos, entonces va a dar un crossmatch positivo. Testeamos varios sueros. Perdón, el trasplante fue el 14 del 10, el 14 de octubre. Testeamos varios sueros y lo mismo, todo nos daba que era negativo, el único DCA a muy bajo nivel. Bueno, cuando miramos todos los sueros a lo largo del tiempo, también teníamos el anticuerpo contra CW4, que era el más constante, no era un DCA, ese era el más alto también, y después varios anticuerpos, y uno de estos era, bueno, acá no está la 24, pero la 24 apareció después. También en esa época no usábamos EDTA. El EDTA sirve ahora para evitar que haya el efecto prosona, que es el efecto de dilución. Entonces hacíamos una dilución del suero para ver si existía efecto prosona. El efecto prosona, cuando hacemos dilución, es lo que esperamos en este suero. Si no hay prosona, si hay prosona, los anticuerpos suben cuando uno hace la dilución, ¿ok? Y eso no es lo que uno espera, pero eso puede llegar a ocultar anticuerpos que son muy altos en el suero original y en un flow cross-match van a dar un flow cross-match positivo. Pero en este caso el flow cross-match fue negativo y no había efecto prosona en esta muestra. Obviamente este caso es un caso para aprender. Tuvimos el trasplante el 14 de octubre, el 22 de octubre, 8 días después, Obviamente esto es una respuesta de memoria, la mujer había tenido varios embarazos, pero más de 10 años atrás, y no sabemos, o sea, asumimos que eso fue la sensibilización de este paciente, pero pueden haber sido otras cosas. Pero lo más probable es que haya sido los embarazos. Cuando miramos, recuerden que esto en este paciente era completamente negativo, cero totalmente. Cuando miramos el patrón después de, esto creo que es la muestra del 22, vemos la gran incremento de todos estos anticuerpos. Algo importante de ver acá es que todos los anticuerpos B, y esto mencioné ayer un poquito, están reconociendo moléculas B que son BW4, ¿ok? Y eso es el epitope BW4, o sea, no están reconociendo, no hay 30 diferentes anticuerpos reconociendo cada uno de estas bits, sino que lo más probable es que sea un anticuerpo reconociendo el epitope del BW4. Y esto lo podemos corroborar porque recuerden que el epitope del BW4 se encuentra en varias especificidades de HLA, que son 23, 24, 25 y 32, y acá están. O sea que esto es todo un anticuerpo. Luego tenemos una 1 y otros anticuerpos, o sea que es una mezcla de varios anticuerpos. Y acá sí, esto es pretrasplante. 8 después del trasplante y 3 días después, y vemos cómo acá se inició el tratamiento con plasmaféresis IVIG, pero obviamente el anticuerpo ya estaba muy grande y muy alto y no se lo podía bajar. También hicimos las diluciones para ver el efecto prozona. Si ustedes recuerdan, el 14, la muestra pretrasplante, no había ningún efecto prozona. Cuando miramos la muestra del 22, donde subieron todos los anticuerpos, podemos ver que hay muchos anticuerpos que con la dilución aumentan el MFI. Muchos de estos eran DSAs. Bueno, esta era la tipificación del donante. Y estos eran los DSA, esto ya es al tiempo. Subieron mucho, lamentablemente el órgano ese se perdió. Y a menos de 4 o 5 meses los anticuerpos bajaron. Pero ahora tenemos un historial de la paciente y sabemos todos los anticuerpos que subieron con memoria. Este paciente fue listado de vuelta y en el 2015 consiguió un nuevo órgano para el cual evitamos obviamente el BW4 y los otros anticuerpos como A1, y otros que eran muy altos. Pero bueno, creo que esto es todo. Entonces, las conclusiones de esto es que hicimos cuando por cómo nos perdimos eso, y les hicimos la investigación de hacer otros cross-matches con diferentes sueros, estudiar las muestras con diluciones, y lo que les demostramos es que no teníamos forma de haber predecido la respuesta de memoria en este caso, ¿no? Entonces, a pesar de que uno puede tomar la estrategia de decir, Bueno, no trasplantamos nada que tenga un anticuerpo arriba de 1000, porque la 24 era 1049, ¿no? Entonces, pero como decís, si no te animás a hacerlo, no trasplantas a nadie. Entonces, si tomamos esa estrategia en la Clínica Mayo, en vez de hacer 350, 400 trasplantes, van a ser 150 o 180 trasplantes, como pasa en otros lugares. Bueno, y yo creo que con eso ya termino.
¿Qué tal? Buenos días, yo soy el doctor Sobrecasa, unidad de trasplante renal. Bienvenido a Tucumán. Gracias por estar acá. Le voy a presentar un caso de una paciente de 22 años al momento actual. En el 2008, que la llevé en el 2011 a ingresar en diálisis peritoneal. En el momento del diagnóstico de la insuficiencia renal tenía complemento normal, no tenía transfusiones, no tenía antecedentes de donante cadavérico el día 23/5/2018, teniendo ella 17 años. Un donante cadavérico, causa de muerte, traumatismo encefalocraniano, paciente obeso, creatinina de 0,7. La inyección que se realiza es con timoglobulina, solumebrol y micofenolato mofetil, un tiempo de isquemia fría bastante bueno, de 5 horas con 15 minutos, un mismatch CMB donante-receptor positivo para el donante, por lo cual recibe profilaxis CMB con ganciclovir durante 6 meses, un panel de reactividad de Luminex de clase 1-0, clase 2-0, del día 2/4/2018, serología para Epstein-Barr pretrasplante positiva. Y ahora vamos a ver su evolución. La evolución el 5/9/2019 presenta deterioro de la función renal. Una creatinina previa de 0,77 asciende a 1,33. Asociado a esto a dosajes erráticos, mala adherencia, y por lo que se planifica una punción biopsia renal, más la solicitud de anticuerpos anti-HLA. La PCR nos arroja 51 glomérulos, 53 glomérulos, perdón, uno de ellos globalmente esclerosado, infiltrado inflamatorio severo mixto, linfoplasmocitario, fibrosis leve, NTA leve, atrofia tubular leve, capilaritis peritubular y C4 positivo, dando como un rechazo mixto BANF2A. La conducta que se toma en este momento es 3 pulsos de solumegrol de 500 miligramos cada uno, una hemoglobina 2 gramos por kilo, asociado a 6 sesiones de plasmaféresis. Bueno, y el resultado de los anticuerpos, tenemos a 10.000 de MFI. La evolución también de la paciente presenta diabetes por trasplante con una prueba de tolerancia oral a la glucosa de diciembre del 2018 positiva, y empieza tratamiento con antidiabéticos orales. Bien, perdón, no había dicho, el mismatch entre HLA entre los pacientes era 5, B38 y DR1. Básicamente lo remarco por la importancia que va a tener después en el seguimiento de los DCA de este paciente. Perfecto, esta es la evolución de la creatinina versus dosaje de FK. Como podemos ver en azul, los dosajes de FK son bastante, una variabilidad mayor al 25%, una montaña rusa básicamente, muy poca adherencia. En donde está la flecha es donde realizamos la biopsia aproximadamente al año, y la creatinina, como vemos, post-trasplante está en rojo, viene descendiendo, se mantiene en niveles bastante buenos hasta el primer año, y de ahí empieza a ascender. Como sabemos, la creatinina es un marcador ya un poco tardío, esto es una culpa que tenemos que hacer todos, porque nosotros no realizamos biopsia de protocolo. Entonces, como que sí llegamos un poquito más tarde a la fiesta, digamos. Estas son las imágenes seguidas para la doctora Aybar. Muchísimas gracias a la doctora Aybar que nos dio las imágenes de anatomía patológica, donde se ve infiltrado, se ve tubulitis y se ve necrosis tubular aguda. Bien. Acá también tenemos otros focos esto es una toxina, focos de tubulitis. Esto es un PAS que tiene, básicamente, están teñidas de azul las células, sería esto, las células inflamatorias. Y bueno, esto nos estaría hablando de la infiltración del linfoplasmocitaria del riñón. Acá tenemos C4b, peritubular, bastante positivo. Y ahora nos viene una pregunta: biopsia de protocolo o seguimiento con anticuerpos. Que pensaríamos sería que si podemos hacerlo todo, buenísimo. Nosotros no las realizamos por cuestiones de logística y de costo, pero bueno, sí seguimos anticuerpos donante específicos. Y bueno, dice el 6 de diciembre del 2021, con la finalidad de mejorar la adherencia del perfil metabólico de la misma, se inicia una cuádruple inmunosupresión con Belatacept, BFK, mofetil y prednisona, llevando valores de creatinina de casi 5 a valores de 1,9 al momento actual. Entre 6 y 8, posteriormente entre 4 y 6, y después de esos 3 meses dejarlo entre 4 y 5. Al momento actual el dosaje de la paciente es 4,7. Bueno, las complicaciones que podemos tener posteriores a este tratamiento que tuvimos el rechazo sumado al Belatacept son tuvimos 3 o 4 en un año, y por E. coli, en 9 meses que no tiene una infección, y bueno, se consigue una función renal estable, con un seguimiento bastante cercano de la paciente, por lo que tiene que ir a hacer las infusiones mensualmente, y para evitar complicaciones. Y lo que sí nos quedaba pendiente, es la biopsia de control de la paciente, para ver cómo modificó la conducta que tuvimos. Lo que podemos, acá está de vuelta, en casi a los 3 años se inicia Belatacept, y acá tenemos el seguimiento de los anticuerpos, de los BCA, ¿bien? Por eso decía la tipificación HLA, al día de la biopsia, los anticuerpos lo único que teníamos era el DQ5 a un MFI de 10.000. Al 9 de 8 del 2021 aparece A1 y aparece A68, y continúa siendo DQ5 el anticuerpo persistente. En el 21 del 10 del 2022 continúa A1, A68, DQ5, y se suman B38 y BR51 a un MFI bajo. Bien, y esto es actualmente el 2023, en septiembre, donde estamos esperando una mejoría, la mejoría de la creatinina, y queríamos ver si la paciente había mejorado realmente su perfil de anticuerpos. Y lo que nos logra encontrar básicamente es que el perfil de anticuerpos, lo que es clase 1 sobre todo, se logra corregir ahí, pero lo que es clase 2, desgraciadamente no hemos logrado volver a bajar el MFI. Si bien el MFI no cuantifica títulos, sí cuantifica la vida de un anticuerpo por un antígeno. La otra pregunta que nos surge es la cuádruple terapia de inmunosupresión. Chance de infecciones, más chance de neoplasia. No hay mucho, digamos, en cuanto a esto. Me encontré una revisión de un equipo FIBA del 2016, que básicamente tenemos pacientes de 1.220 pacientes, de los cuales 458 tomamos Belatacept solamente, 417 tacrolimus más Belatacept, y el grupo control, que es el grupo más grande, los que tomamos tacrolimus, ¿bien? Sí se encontró con respecto al estudio Benefit, mayor tasa de rechazo, que la lleva casi un 15%, en los pacientes que tomaban Belatacep. El riesgo de infecciones, en 2 estudios distintos, con Kaufman y Wood, las infecciones severas no eran significativas en ninguno de los dos, no había diferencia significativa en ninguno de los dos grupos que tomaban Belatacep o que tomaban Belatacep más tacrolimus o con inmunosupresión basal de tacrolimus. Y tampoco había diferencia en infecciones oportunistas como CMV, BK y demás. Esto sería el gráfico de la comparación entre lo que vemos. En la barra negra está Belatacep más tacrolimus, en la barra gris está Belatacep solo, y en la barra blanca está tacrolimus solo. El porcentaje de rechazo según esquema, donde se ve una clara diferencia a favor de tacrolimus, ¿bien? Esto es lo que nos arrojaba este estudio. También cuando vamos a ver el tema de neoplasias, vamos a ver el tema de neoplasias y perfil metabólico, la gran diferencia que hay en el grupo Belatacep versus tacrolimus, y no hay gran diferencia entre lo que es metaplasia, lo que es neoplasia y lo que es PTLD entre los dos grupos, ¿bien? Y esto es un esquema que nos dan de orientativo de cómo switcharlo al paciente, de cómo adicionar tacrolimus a Belatacep. Día 1, hicimos al día 14, al día 28, y de ahí durante 5 miligramos por kilo, durante cada 28 días. El tacrolimus se fue disminuyendo gradualmente, de día a 12, de 8 a 6, y bueno, después hasta litro. Y el mofetil fue 1 gramo por día y el ácido micofenólico 720 miligramos por día. Bien, entonces la conclusión de este caso es tenemos que poner foco en la adherencia de los pacientes a la terapia inmunosupresora, utilizar protocolos de seguimiento y anticuerpos anti-HLA en la valoración evolutiva de cada paciente, el adicionar Belatacep como cuádruple terapia inmunosupresora para mejorar la adherencia y el perfil metabólico en estos pacientes con diabetes, eso es lo que hay que valorar. Sumar Belatacep al tratamiento inmunosupresor puede cambiar el perfil de los DCA, siendo poco efectivo en los de clase 2. Estas serían las conclusiones que podemos llegar a sacar de un paciente puntual. Lo que nos permitió realmente adicionar Belatacep a este paciente fue mejorar el control metabólico y mejorar sobre todo el control clínico y la adherencia. En eso sí es un punto fuerte que hemos tenido en este caso, porque la paciente la verdad que era muy complicada el seguimiento. Como ustedes han visto, los dosajes eran una locura, eran totalmente erráticos, y bueno, las tasas de infecciones no han sido 5 años después, no han sido severas ni tan frecuentes y se han podido controlar. Este es nuestro equipo, y como detrás de todo paciente hay un equipo, este es nuestro equipo, acá estamos con nuestros pacientes, y les quería agradecer a todos por venir a Tucumán. Muchísimas gracias. Espero que no haya sido